We know that the environment has an impact on heart rate variability, and this is an example from a study that showed that when ambient particulate matter and air pollution, if you will, accumulates, that the heart rate variability in older adults declines dramatically. And that may account for one of the reasons why highly polluted areas, heat stroke, which causes a lot more, heat waves, cause a lot more ambient particulate matter, maybe part of the reason or the mechanism by which older adults succumb during heat waves. I want to talk a little bit about the heart and aging. So it turns out that as we get older, a third to a half of the population has systolic blood pressure. So certainly all 65-year-olds will have, a third of them will have high blood pressure. By the time they reach 80, if they do reach 80, 70% of them will have systolic hypertension. Part of the aging heart is that diastolic relaxation declines, and so the heart is not able to accept as much blood as younger. And so in some cases that problem with diastolic relaxation results in diastolic heart failure. There's also a decline in the refractory period by which the heart recovers and basically creates the squeeze to push the blood out. Associated with the aging heart is the aging respiratory system. There's this concept of senile emphysema where the alveoli enlarge. They're not destroyed, they just become more bulbous. And as a result, there's less surface tension and less recoil. Interestingly, there is some studies that show that there's an increased migration of macrophages. Part of this may be due to the accumulation of what we call the senescent cell phenotype. These are large fibroblasts that reside in tissue. They no longer have replicative potential, but they tend to exude inflammatory signals, thereby potentially increasing and recruiting more macrophages into the system. And that may be one of the theories behind the so-called cytokine storm that occurs with aging. Here's a table of different pulmonary changes. Just want to bring your attention to the FEV1, forced expiratory volume in 1 second, declines with age. And one of the other points that I want to make are the VQ inequalities, so that there's lower ventilation in the lower half of the lungs, and for that reason that we want people as they get older to be sitting up rather than lying down for optimal gas exchange. So here's an example of the FEV1 declining with age. So you can see, interestingly, that there are some old people that look like young and some young people that look like old. And so there's, again, variation in lung function as you look at a population from age group to age group, here from 25 years old to 75. With these pulmonary changes with age, the older adult, as you can see here, increasing age up to 80, that the average pulse ox declines, and so they become closer and closer to a hypoxemic state. So the clinical implications are that you get potential atelectasis that promotes hypoxia as well as pneumonia, so that's why deep breathing exercises are important. The alveolar mismatch with the blood is exaggerated in the supine position, so we therefore want to try to promote upright positioning and deep breathing exercises. Here's a study where in Britain, this is like a 2008 study published in the British Medical Journal, that showed that Mr. Smoker, if you're the age of 50, you have the lungs of a 75-year-old, and by stopping smoking, you can delay this course of lung deterioration. During the study, it was found that by showing middle-aged smokers their age equivalent lung function, that 40% of them decided to stop smoking, as opposed to the traditional methodology of the physician or provider wagging their finger at them and say, "You, sir, must stop smoking," which only accomplishes about a 10% cessation rate. So this is one of the cases where ageism is used beneficially to change smoking habits. All right, so I just want to keep emphasizing that the supine position exaggerates decreases in PO2 and hypoxemia, so we get I guess a green star as opposed to a gold star for keeping our older adults up and moving around. Just also mention that in terms of lung aging, that there's a steady increase in cancer with age, obviously compounded by secondary smoke and primary smoking. So moving on to the gut with aging, we mentioned that dry mouth is a problem in quite a few older adults. This can lead to exaggerated problems with dentition, gingival recess, tenderness. And if somebody's starting to lose weight in the older adult population, first thing to do is look at the dentition, look for pain, particularly in older adults with cognitive impairment who may not be able to express problems with eating. So 10% of all of us actually have some form of silent aspiration, but because of the reduced oral to pharyngeal phase of pushing the bolus into the esophagus, that silent aspiration can increase up to a third of the population who are 90 and older. So you can see, as a consequence of age, that by the time you're 100, you're 100% chance of aspirating, and that all comes from this dyskinesia that occurs in the oral pharynx. Some of the key features that we need to think about in normative aging with the gut is that there are reduced contractions, less peristalsis, decreased acid clearance, which predisposes people to gastritis, particularly with the NSAIDs. But one of the big points I want to make is the reduced antral volume. So this leads to early satiation, and clinically and practically speaking, it has some implications, because if, for instance, you provide dietary liquid protein supplementation with each meal, that high protein load is going to cause early satiation, and people, older adults that is, will not consume a full, regular meal. And so as a consequence, we often in geriatrics encourage people to take protein liquid supplementation in between meals rather than with their meal. Already mentioned about the issue with acid clearance. There's certainly normal acid secretion with age. So one of the things that we notice with the aging gut is that there's an increase in reflux. Part of that may be related to the 30% of the aging population that's obese, as well as for other reasons. But one of the implications for this is that there's an awful lot of proton pump inhibitor prescription, as well as H2 blocker prescriptions. More recently, Zantac was taken off of the market because of contaminants that are highly carcinogenic. And there's a movement afoot to reduce proton pump inhibitor use long-term in the older adult population for two reasons. One is that proton pump inhibitors predispose older adults to accelerated osteoporosis. And secondly, it predisposes them to C. diff colitis if they are on antibiotics. So in terms of other issues with intestinal aging, there's some minor changes in the small bowel. So there might be a little higher population with lactose intolerance. And so somebody that comes in to the clinic and talks about loose bowels, diarrhea, that you might consider lactase deficiency as your first line of thinking. There's also a higher incidence of bacterial overgrowth leading to decreased B12 absorption, as well as folate. And the folate, a recent article showed that diabetics in particular are most susceptible to folate deficiency. I want to just emphasize the dreaded fecal impaction. There's a lot of reasons for this occurring with age, but in your review of systems, it's so important to find out when the last bowel movement occurred, and if somebody tells you 2 to 3 days ago, that could be an issue, particularly if they have a confusional state, and if they in that confusional state can report problems with their bowels, because in one study up to 40% of delirium or acute confusional state in older adults was attributed to either fecal impaction or obstipation. So musculoskeletal changes with age, need to think about who are you comparing it to. Are these unconditioned versus those that regularly exercise? But suffice it to say that there is a steady 1% loss of lean muscle mass per year after the age of 65. What we see here are age graphs going up to 100, and you can see the steady decline in both arm strength and grip strength. We actually recently published an article with Dr. McGrath that looked at asymmetry of grip strength as a proxy measure for functional disability in the older adults. But again, because of the steady march of muscle mass loss with aging, it is so important to prescribe resistance training in the older adult. And no matter what the age is, there was a Dr. Fattori study many years ago that showed that even 90-year-olds can benefit from resistance training minimally twice weekly for 30 minutes. So the clinical implications of the aging muscle is that we get this concept of sarcopenia or dynopenia, where you get both muscle mass loss as well as overall weakness of the remaining muscle. And so as a consequence of that, a lot of people are unable to do just very small minor lifting, and as a consequence they have problems with their daily tasks. And so when you say somebody has problems transferring from the bathtub or shower back to the bedroom, that's in part because of this loss of muscle mass. And just be mindful of the fact that hospitalization is the biggest risk factor for loss of muscle mass. So there's actually an epidemic of sedentariness in the older adult population that is hospitalized. So here's an example, where physical activity prevents functional decline in older women. So exercise improves active life expectancy. And remember, active life expectancy is that period of time with preserved functional status. In terms of skin and integument, I think some of this might be self-evident in terms of epidermal thinning. I just want to bring attention to the low vitamin D levels, because as people get older, they become more homebound, less likely to be outside, and as a consequence, they get low vitamin D levels. All right, so here's 6 different pictures for a common condition in older adults, which is herpes zoster. So I want you to take a look and see which of these pictures you think most represents the grape-like clusters of shingles? Okay, so if you had picked item 4, the slide that is most representative of zoster, you can see that there's little grape-like maculopapules with an erythematous base, which is different than herpes, or impetigo, which is more confluent, as opposed to insect bites, which are spaced in somewhat of a random fashion, but not in a cluster of grapes, if you will. So just to remind us all that zoster increases with increasing age, and one of the interventions is to have the Shingrix vaccination for older adults. I often tell my patient population that at least 33% of shingles occurs on the face, and of that, 50% is associated with eye involvement, and so you'll have both reduced vision, if not the worst and extreme case of total loss of vision. So vaccination, I think, needs to be emphasized for those that are reluctant to do so. So I want to talk a little bit about nutrition and longevity. So I had mentioned this Adventist study, and it just really has impressed me that the extra years of life expectancy gained by a vegetarian forward diet is quite dramatic. Those that have vegetarian with milk and eggs get intermediate benefit. But this really, I thought, drove home the concept of you are what you eat, and that along with this improvement, there is increased functionality in the older adult population. It may not be based on this study. It may not come as a surprise that Loma Linda, which has a high concentration of practicing Adventists, that they have a exceptionally high longevity, and so they're considered a longevity zone in the world, along with Okinawa, Costa Rica, and an island in Italy called Sardinia. So, excuse me, it turns out that telomere length can be altered by aging and inactivity. So the good news is that by becoming more active, that the telomere length can be rejuvenated, and physical activity is an important intervention. Turns out that most of the studies are showing that more is better. So a recent study demonstrated that 8,000 steps per day is associated with an overall reduced mortality by 50% in people that accomplish 8,000 steps a day or more. There's other studies that reducing cardiovascular risk factors are improved dramatically with longer duration of physical activity and higher intensity. So again, more is better, such that you get 10 to 20% reduced cardiovascular risk with moderate activity, but if you go to 90 minutes with high intensity, you get up to a 40% decreased mortality risk. So turns out that our current odds of living to 100 are about 1 in 4,000. We might be able to influence that royal flush goal by improving our diet and physical activity. But I just want to also say that this ratio is going to change. So children that are born currently will have a 1 in 100 chance of living to 100. So we really do need to prepare ourselves, our healthcare system, for dealing with the fastest aging group of all, which is the 100-year-old and older population. So just to summarize, we talked today about the demographics that show a population explosion in older adults. We looked at what we consider normative aging and how that might help us clinically. We also know that not everybody at the same age looks alike from an age lens. And so we need to address their function rather than their age as we make clinical decisions. And one of our goals clinically and through health promotion is to preserve, if not extend, functional longevity. So I would like to wrap up this presentation by saying aging, if it's not your issue, it certainly will be. Thank you.